Okay, Shannon, so I don't feel I need to introduce you again, but this is part two of our discussion with Shannon Emmett about haematology and her interest. Now, in the first part, we talked about iron, and I wanted to use that to get into your particular interest. And I know there are a number of causes for iron deficiency, but I know that one of the causes is pregnancy. And I recall having a conversation with you previously, and you told me that a lot of patients show up for you because they've been found to be iron deficient in their pregnancy, but there's actually something underlying that. Now, is that how it happens in practice for you?
Yeah, very much so. So for women, the most common, well, the things that we think about for iron deficiency are they eating it, are they absorbing it, and are they losing it?
Yeah.
So sometimes there can be a dietary cause or dietary choices that cause their iron levels to be low. But often for women, it's their period losses.
Yeah.
And so they can either present due to that, or in pregnancy, having gone through heavy periods and now being pregnant, and then their iron's getting checked for possibly the first time, or they get anemic and then the iron gets checked. And so, unraveling the cause for the iron deficiency, it often is this concern of heavy menstrual bleeding. And so the underlying cause for that can be an anatomical thing. So obviously it's checking for fibroids and polyps and those sort of things. It's often a hormonal thing, but in up to 14% of women, it can be an inherited bleeding disorder.
Oh, right, okay.
And so the best thing is if one can actually catch them before pregnancy, because the coagulation factors change with pregnancy.
Right.
Pregnancy is a phenomenal, the phenomenal physiological changes that occur, and one of them is to protect against blood loss at time of delivery. So some of our clotting factors rise by up to threefold during pregnancy.
Right.
So sometimes it can be a little bit tricky to diagnose an inherited bleeding disorder during pregnancy.
Right.
So ideal to be able to see them as a preconception, or because they've got iron deficiency or heavy menstrual bleeding as their story, and then being able to do their coagulation tests to work out if there is a problem there. The most common is von Willebrand's disease.
Right.
And that in itself, there are many types of von Willebrand's disease. And so if we can work that out, we can actually then help them better with their period losses, prevent them from having what can be, incredibly life-intruding periods, which for some young girls, they don't even know that that's not actually okay or normal. And then getting them into a good state before pregnancy. So as I mentioned before, so iron deficiency by definition is a ferritin below 30. But if you start a pregnancy with a ferritin below 70, you're probably going to land up iron deficient during it.
Right.
Now there is some variation in that obviously, but in broad brush strokes. So in an ideal world for me, on booking bloods, I'd be doing a ferritin on everyone. You don't even have to do the full iron study, because those women, it's unlikely that they're going to have some underlying malignancy or something that's causing acute phase reaction and pushing their ferritin up. And if they've got a low ferritin, there's only one thing that causes a low ferritin, that's iron deficiency. So simple, just on booking bloods, to be able to just do a ferritin, to be able to pick up if their iron's low. And get them onto just some oral iron early. And that in itself might make a difference and prevent them from needing an iron infusion later on in the pregnancy. Because pregnancy just consumes iron enormously. So there's some beautiful research that's quite old now, but just showing how the demands on iron rise through pregnancy. And by the third trimester, so from 28 weeks on, the amount that you need every day is more than you can absorb every day.
Right.
So if you get to those that 26 to 28 week glucose tolerance test is another really nice point to check where the iron's at. Because if it's low, then they are not going to be able to replace. They're not going to be able to replace it with dietary iron alone.
Okay.
Even if you supplement them from then, because they can't absorb what they need, and so they're going to be. It will help, but they're still going to be eating into their stores. So by the time they get to delivery, they could be anemic, and then you're in a whole different situation, because we know that because of flow dynamics, anemia increases your bleeding.
Right.
So if you come to delivery anemic, you're more likely to have a postpartum hemorrhage.
Yeah.
You're not going to recover as well. And this is one of the biggest areas worldwide, is that we lose mothers from postpartum hemorrhage.
Right.
And it's one of the most it just upsets me terribly. Actually, I shouldn't go into the subject, but it's one of the...
I haven't gone in any tissues.
Anyway, I mean, if there's one thing in my life that I want to get involved with, it's this, because, postpartum, loss of mothers from postpartum hemorrhage.
And it sounds like in this country that should be unnecessary, from
and
iron deficiency.
Exactly, that in this country we're so privileged, but what we also, just because we're not, postpartum hemorrhage does happen, but just because we're not in a third world country doesn't mean that iron deficiency doesn't matter. We have women who are, hugely socially involved, working mothers with small children, running, with so many hats on, who then are also trying to do that iron deficient. And we've spoken about what it feels like to be iron deficient, and you just don't function as well. And so this whole idea that, as long as you're not anemic, it's okay, actually isn't okay.
Yeah, okay. Oh, that's good.
I feel strongly about
you do. I think we might just have to stop the video for a second and we'll come back to that. Okay, you mentioned von Willebrand's as one, and that makes you bleed, obviously. So I'm presuming there'll be a whole bunch of conditions when you're pregnant that will make you bleed. But you also mentioned that you have more clotting factors, so I'm imagining there's a whole bunch of conditions that will make you clot as well. And blood doesn't seem very fair to me. It's you're either one way or another. So what other conditions, just in small little nutshells, so my little brain can cope with them? Could you maybe go through a couple of the bleeding conditions you see, and maybe a couple of the clotting conditions that you would look after as well?
Specifically in pregnancy?
Yes.
So, from the bleeding side of things, with the inherited bleeding disorders, as you mentioned, von Willebrand's factor rises threefold in pregnancy. So, for 80% of those with von Willebrand's disease, it's type 1, which just means they've got low levels, and so they're usually okay
so
for delivery.
Fine.
So we check their levels. They often kick quite late, but from 36 weeks, as long as we've got a good enough level, then sometimes we just use tranexamic acid after delivery, and they're usually fine. It's the type 2s, and there's 4 different types of type 2s, where it's a functional problem with the von Willebrand's factor, and then that rise isn't enough, because that, even though there's more of it, it still doesn't work well. And then we have to replace that von Willebrand's factor with Biostate for delivery.
Right.
Then there are other clotting factors that can be deficient and that don't necessarily rise. So like factor 11 doesn't rise with pregnancy. So we've got a couple of ladies around who we then have to support for delivery with some product, and that's another whole can of worms predicting how that's all going to go. And then the platelets. So platelets are those little fragments of cells that clot the blood and interact with those clotting proteins and with the blood.
That was exactly the right level, by the way, for me. The little bits that clot the blood. Great. That's good. We're getting there. That's good.
So they're fabulous little things. And so first you've got to have enough of them. And so in pregnancy, one of the amazing things that happens is that our blood volume increases significantly.
Right.
So that blood volume doubles, and that's why you see pregnant ladies, they've got great veins contamination.
Great. Love them.
But that means that it dilutes both their red blood cells and their platelets. And it's an amazing physiological situation, because it also makes the hematocrit of the blood lower. So the flow through the placental low pressure system is nice and smooth. But it also means that when they bleed at delivery, they're not losing as many cells. And then when they have the big diuresis post delivery, they actually almost concentrate their cells up again. It's amazing. It's amazing. But what it does mean for the platelet count is that almost everyone's platelet count falls in pregnancy because of that dilution, and 11.4% of women will have a platelet count between 100 and 150, so in that thrombocytopenic range, but it's what we call gestational, it's dilutional, it doesn't cause any problems, it's not an issue for baby, and they don't have any increased risk of bleeding. It's when the platelet count is less than that, then we start to investigate what else is going on.
Right.
So we have a lot of women that we see who have immune thrombocytopenia.
Right.
So it's when their body's making antibodies against their own platelets and clear out the platelets faster. And then often, unlike most autoimmune conditions that actually are quite quiet and well behaved during pregnancy, ITP often gets worse.
Oh, right, okay.
And so we often have to monitor them quite closely and treat them with, we try and use just a small amount of prednisone, and a couple of reasons why we can't use big doses, and or IVIG, which we can give close to the end to try and keep the platelets up for delivery.
And I'm guessing that because there's 2 patients involved at that stage, the little... And that presumably makes managing that more complicated, does it? Yeah.
Yes, very much so. So for some of our ladies with immune thrombocytopenia, the antibodies can cross the placenta and cause thrombocytopenia in the baby.
Right.
It's not common, but it does happen, and it can be really quite severe. And the mum's platelet count does not predict what's going to happen with the baby's platelet count. Your only prediction is what's happened in the last pregnancy. So if you're in your first, you've got no guidance. So the nice thing there is that the IVIG does actually help to mop up those antibodies, and the baby's platelet count is often a lot better if we've had to give IVIG before delivery. But what it means is we always say, please don't do anything that would increase the baby's bleeding risk. So no Von-2s, forceps, fetal scalp monitoring, and send a cord blood in the baby immediately for a full blood count so we can see what the platelet count is doing. Those antibodies, if they've crossed across, can be in the baby's circulation for up to 3 weeks after. So we do a cord, and then we ask them to please do a baby full blood count again between days 2 to 5, just to check that it's still staying up.
Right.
Cool. So yes, 100%. We're always thinking about people.
And so I'm just cautious that we're going to end up talking for hours and hours about this, which is interesting. But what about clotting? What about the clotting side of things? Where what conditions do you see flaring up more regularly in pregnancy when it comes to clotting disorders? So
bleeding and clotting are, along with cardiac disease, are the biggest killers of women in pregnancy.
Okay.
So clots are 4 times more likely to have generally a clot during pregnancy than when you're not pregnant.
Yeah.
And that's because of those rises in those clotting proteins, the changes in those clotting proteins, and that happens from really early on. So particularly from an ED side of things, it's really important that if a woman comes in with a suspected clot, to always check that she's not pregnant, because any of our treatments other than clexane can have teratogenic effects for bubs. So like when we were using warfarin, there were a couple of horrible case stories where ladies had been started on warfarin in, after that 6-week point in the first trimester, when you can have problems with implications for baby, and the DOACs as well are contraindicated in pregnancy.
Right, okay.
So important always that if someone's got a new clot and they're of childbearing age, you want to just check that they're not pregnant.
Yeah.
And before starting any treatment.
I guess from my memory, or to remind me, that doesn't also end when they have the baby, does it?
No, exactly.
There's still a period in the postpartum period where they're procoagulant.
Exactly.
How long does that usually last, or is it hard to say?
No, it's well studied. So 6 weeks is there's a significant rise in the coagulation factors out to 6 weeks. Yeah. But actually, it's only from 12 weeks postpartum that the coagulation proteins are the same as a year postpartum. So, so that 6 to 12 week period is still a time when there is, they are still more likely to have a clot than if they weren't in that phase. For for most of our ladies who we've had to have on anticoagulation to prevent a clot during pregnancy and then taking them all the way out to 6 weeks postpartum, most of them, you can't make them go anymore. But occasionally there are people that we've got to actually keep going for longer. And occasionally we do see clots happen at 8 weeks and they've stopped at 6 weeks.
Yeah, okay.
So the other things, so Virchow's triad, so it's the clotting proteins, the flow dynamics, and the changes in the blood vessel wall. So the flow dynamics are a big thing in pregnancy. We've spoken about the blood vessels being fuller, but importantly, the gravid uterus pressing on the veins as they're travelling up from the lower limbs is an issue, and particularly from the left side. So lower limb clots are much more common on the left than on the right in pregnancy, because that vein has to cross behind the uterus to get to the IVC.
Oh God, we have to know anatomy as well. Biochemistry, haematology, and anatomy. Okay.
And interestingly, much more common to get a proximal clot in pregnancy than outside of pregnancy. So sort of up to 13% of clots outside of pregnancy will be only proximal, whereas we get, depending on the study, 35 to 78% of clots being isolated proximal clots in pregnancy. So again, low threshold for suspecting a proximal DVT in a pregnant woman, and sometimes it can be really hard to pick up because an ultrasound might not be able to get high enough to see it, and sometimes we have to use an MRI to diagnose a proximal clot in pregnancy, and so that's, it's not a common situation. We've seen someone who've had an ultrasound and then a week later another ultrasound, and then it's been seen.
And then, as you alluded to, treatment is Clexane. Pretty much. So during pregnancy,
it's Clexane because it's a big molecule, doesn't cross
the placenta.
So we don't have problems with bleeding. My practice is to try and get them down to, depending on when the clots occurred, to try and get them down to a prophylactic dose from 36 weeks onwards. Obviously, if the clot's been close to then, that's not an option. But to really try and make the delivery period as with as little interference as possible. And then postpartum, it's so management of delivery is part of the fun stuff. Planning how timing of Clexane and motor delivery is dependent on obstetric indications rather than their anticoagulation and so forth. So you're not going to have a Caesar just because you're on Clexane. And then postpartum, it depends on whether they breastfeed. So if they're going to breastfeed, then it has to be Clexane. They can have warfarin, but with the warfarinization process postpartum, you can imagine you've got a new baby, now you've got to have INRs and all of that. It's just...
It sounds like if you've got your way through pregnancy with Clexane, then trying to change to warfarin is just the...
So
may as well keep injecting.
But now with the DOACs, if they're not breastfeeding,
you could change them to a DOAC,
if they're not breastfeeding. So it's only one case report on rivaroxaban use and it going into the breast milk. I did actually do this study myself.
Oh wow! Okay.
Like literally myself.
I should get you to sign.
The problem was the breast milk was so lipemic they couldn't test it.
Oh okay.
It was. I tell you, that's we need a drink to tell that story. To be honest, that was really.
I think I would need a couple of drinks.
I need one too. The trauma of it. But then apixaban, interesting, is actually actively excreted into breast milk.
Oh, okay.
So it's a definite no-go.
Okay.
And then,
So what about other, I guess, clotting disorders that you would find yourself managing regularly in pregnancy? Is there anything else that seems to come up?
So, we obviously prevention of clots is a big thing. So not just treating those that have occurred, and so where the other things that come into if a clot has happened in pregnancy, obviously the pregnancy will increase your risk, but the important thing is getting a family history. So if there's a family history of a first degree relative, so mom, dad, or sibling who's had a clot, particularly an unprovoked one, that really should be a red flag to be thinking that there might be more to the story. And in that situation, I would do thrombophilia testing. Now that may not necessarily change the dosing of it for management of an acute clot, but it would potentially change your dosing for prevention of a clot.
Yeah.
So family history is really important. And then antiphospholipid syndrome. So that's another whole big area that we get involved with.
Yeah.
So fascinating subject.
Yeah.
But so antiphospholipid syndrome can either be obstetric, so what it is, it's antibodies. So there's 3 antibodies that we can check for that increase blood clots, and they can be both arterial or venous clots.
Right.
So and then it can also have obstetric presentations. So recurrent miscarriages or later losses, placental disorders, increased risk of preeclampsia, intrauterine growth restriction, abruption, so forth.
Am I right in thinking that some of those conditions particularly people only really know about them when they start to try and get pregnant, because they have a number of miscarriages and then somebody
and that's often it, So the other route for coming into being tested for antiphospholipid syndrome can be thrombocytopenia.
Right.
So although thrombocytopenia isn't a clinical criteria for calling it antiphospholipid syndrome, it's still a recognized, one of the recognized features of antiphospholipid syndrome. And so I actually see quite a lot of women who have thrombocytopenia and have antiphospholipid antibodies, and they haven't necessarily had a clot.
Right.
Some of them have some obstetric have obstetric antiphospholipid syndrome.
Right.
And it can be really quite.
So how are we picking those? So that would be maybe general practitioners doing screening bloods, noticing that their platelets are low, and then investigating further. So
it would be, as you say, if the platelets are low, if they've had recurrent miscarriages, or if they've had a blood clot, and a blood clot in a young person, you've got to be checking for antiphospholipid syndrome.
Yeah. And how do you actually manage those through pregnancy then?
So it depends on what it is.
I feel like I've asked another question that's going to be impossible to answer. Okay. So in 30 seconds,
Clexane. Aspirin, Clexane.
Yeah.
So if it's obstetric, aspirin and Clexane to try and it's not necessarily that they're not necessarily forming clots of the placenta. There's something. It's an inflammatory. It's a complement-mediated process actually. Yeah. But there's something about the anti-inflammatory effects of those 2 drugs that's probably stronger than the anticoagulant in that setting, that helps with the placentation, which is 3 to 16 to 20 weeks. So if you can get those things in early while the placenta's forming, that can make a difference to their obstetric outcome.
Right.
And then to prevent clots, it's Clexane.
Okay, good. Now, I feel like we've ended up talking for quite some time about that as well. It's fascinating. We could keep going, but I just wanted to, I think we should probably wrap up now. And I just wanted to give you another opportunity, and the answer may be a simple no, but is there anything else that you think that you feel strongly about, that you see either myself or my colleagues doing, that you think we should know about, or the local general practice community or the nursing staff? Is there anything that you've thought, I wish I could tell everybody this thing? Or have I opened another 20-minute can of it? No.
I think for all of us it's about listening. So I think when a woman's coming, and they often come in anxious, because they've been trying to sort this out themselves, because that's what they do. Women get on and try and manage everything. And so when they eventually present, sometimes they're anxious, and it may not be that well sorted out, but just checking for iron deficiency. It's so simple, and sometimes that can really just help them. And it may not be the whole picture, but being iron deficient means you don't cope very well. With everything else that you have to deal with. So that would be my message.
Brilliant.
Consider iron deficiency in anything. Headaches, fatigue, palpitations, not coping.
Okay, good. That's great advice. Thank you so much for doing this. I really appreciate it, and I'm sure everybody will.
Thanks for letting me talk.
Yeah, no, that's okay. It's fascinating, and I think everybody else will find it fascinating too. Thank you so much, Shannon.
Thanks.
No problem.